Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Erin McCreary, and I'm the Senior Director of Infectious Diseases Strategy at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, United States. I am joined again today by 4 other fantastic CMI Communications editors to discuss the clinical trials presented at ESCMID Global 2026. This is part 2 of a 2-part series. So if you missed the last episode, please be sure to go back and listen where we covered 5 trials. And today we're going to cover 5 more. We are going to skip bios today. I am joined by Josh, Marc, Anne-Grete, and Angela from CMI Communications. And we're going to go right into our get to know you question. Have you ever been, or would you ever go skydiving? Marc, what's your gut reaction to that?
Well, I can't use the exact words, but no. No.
You can say it and we'll bleep you out.
Canyon, entering a cave underground, speleology or something like that, and this. No way.
Well, yeah, Marc had some choice words in our outline for this experience. My answer is I have never been. I will probably never go, but I wish I was the kind of person that wanted to go skydiving. Like, it actually seems really cool. And I think if someone literally pushed me out of the plane, I'd enjoy that part. I know I would never be able to do it, like to get up there in an open plane and take the step off. I'm too much of a scaredy cat. Angela?
Answer is no.
Josh?
Short and sweet. I think it was Emily who came up with the question.
Our girl Emily, yes.
Yeah, my answer is kind of similar to yours. I can see why it would be fun, but I just am not brave enough to do it, and I know why. It's because I don't have the novelty gene. Have you guys heard of this, the dopamine 4 receptor gene? Polymorphisms in this gene have been shown to correlate with exciting behavior and gambling and high-risk activity. So people that skydive are much more likely to have this gene polymorphism than people that don't. And I don't have it, I'm pretty sure.
And they don't self-eliminate. Like, they don't select themselves out of
exactly. You're right. You think it would be but it's an evolutionary advantage as well, right? Because taking risks sometimes pays off.
So nuanced. Josh, love it.
Anne?
Well, actually, funnily, I had a gift card to do skydiving like 10 years ago, and I never went. I don't know what happened. I think because I moved to the Netherlands and something happened in between. And I felt like this was a sign I shouldn't do it. So I never went, but I did want to. But then I was 10 years younger then, so now I would not do it. No.
So out of all of us, she's the one who's actually like trialed this experiment.
I've actually planned it, yeah, but then it never happened, so.
But also the person who gave you that gift card is listening and like, what the heck? You know, why didn't you? Never getting you a gift
that was expensive.
Oh, all right. Let's get right into our trials. We got 5 more trials coming at you today. We're each going to present one. If one of us has a conflict of interest with the trial we're discussing or choosing to comment on after one of our colleagues presents it, we will declare that before we have our discussion, or we simply won't comment and all of our conflicts of interest are in the show notes for you. Marc, take us away.
Yes, I will start off with the Procalban trial, which stands for the use of PCT, procalcitonin, as a point-of-care test to guide de-escalation of empiric antibiotic therapy in adult patients with sepsis, and here it comes, in a tertiary hospital in Bangladesh. It's a randomized controlled open-label trial and was presented by Farhad Choudhury. Now, I must admit that I do have an emotional conflict of interest related to procalcitonin, especially in the Western world, where this has been fiercely debated, especially for guiding treatment in patients with community-acquired pneumonia, and I have always been on the contra side. No one could ever convince me that this is really a beneficial addition to our armatorium, especially not since we have CRP, which is much cheaper. So now we completely changed the setting. We're no longer in the Western world, we now go to Bangladesh, where 30 to 60% of the bacterial strains are considered multi-drug resistant according to our standards, where there is massive antibiotic use, and there, in the words of the presenter, there is a lack of quality microbiology labs, so not providing sufficient information to guide clinicians, and the choices about what to treat with and how long to treat are guided by clinical judgment only. The utility of biomarkers, including CRP, to guide antibiotic use is very understudied. So after a review study up front for all the possible biomarkers to be used, they made the choice to use procalcitonin, as it was well studied in high-income countries, it is mostly studied in ICU settings with low AMR prevalence, but not yet has it been studied in low and middle-income countries. And in Bangladesh, critically ill patients are generally treated in general wards, and there's a high prevalence of AMR. And the presenter actually showed some pictures on the setting where these patients were treated, which was completely different than where we treat patients, and there was also enormous crowding. So that's where the study was executed. And the intervention was that patients that were started with antibiotics had their PCT measured daily. And if the level fell below 0.5 nanogram per ml, there was a non-binding advice to de-escalate antibiotics. That was the intervention. The control was the standard care. And the follow-up of patients was until 28 days after discharge from hospital. Now, they screened more than 1,000 patients and actually recruited 532 in two groups of 266 patients. It was a population with a median age between around 42 to 45 years, so a young population, with mostly respiratory tract infections, about 50%, 25% had urinary tract infection, and enteric fever accounted for 12%. 18% of these patients, despite the suboptimal microbiology, had bacteremia, mostly E. coli or Klebsiella. The primary outcome was the length of treatment, and the length of treatment had a median duration of 4.7 days in the intervention group compared to 9 days in the standard of care group. The secondary outcome was the days on therapy. So if you have 2 antibiotics on 1 day, you have 2 days on therapy, the DOT, and the median values of those were 7.2 in the intervention arm and 13.2 days in the standard of care. So there clearly was a reduction in the number of antibiotics per day and in the number of days antibiotics were given. The median length of stay of patients in the hospital, though, was comparable, although statistically they said it was a significant difference, but it was 4.03 versus 4.73. So a half a day difference between the groups. And the mortality, as observed in the follow-up period, was 8.6% versus 7.9%, so not a difference. So the conclusion was that in this apparently ongoing project, the procalcitonin was a highly promising tool in this low and middle income setting to achieve a clinically relevant reduction in antibiotic use, and that it also was safe for relevant patient outcomes. And that's what I like very much about these types of studies. We can easily say we can reduce antibiotic exposure, but at the same time we must demonstrate that it is still safe for the patients. They had not a formal non-inferiority co-endpoint, but here at least it was very obvious from the data that there was not a big difference in outcome. And that was a question I really would like to have addressed to the presenter, but this was the last presentation in the session, and it looked like the chair had to catch a plane. So he did not allow any questions and immediately closed the session. So I really would have liked to ask how this non-inferiority for safety will be demonstrated, as I assume that its trial is still ongoing. And the other question is, how would this change their practice now? Because in the abstract, but it was not presented, they also showed us the price and the costs of both strategies per patient day. And there the PCT testing strategy, including the antibiotic use, was more expensive, 20% more expensive than in the comparator. And with no difference in length of stay, which is the major cost driver for cost analysis in hospitals, this would imply a 20% higher costs for a strategy. So it would have been very interesting to hear from the presenter how this is taken into consideration in his country. But actually, I think it was a very well done study, nicely presented, and giving it quite a different view on the possibilities of biomarker-guided therapy in other settings that we are used to work in.
Yeah, I guess one thing I noticed on this is that the duration of therapy in the control arm was a median of 9 days, meaning 50% of people got more than 9 days of therapy. And these are for patients with pneumonia, UTI, and bacteremia for the most part. And we know that 7 days of therapy from the BALANCE trial is sufficient for those with bacteremia and 3 to 5 days for those with pneumonia. So their baseline antibiotic use is already probably too long. And therefore, yes, they've shown a shorter duration with procalcitonin, but I wonder if there would be the same impact if they changed their practice to accord with the latest evidence.
I could also not address the question why they decided to use procalcitonin and not CRP, because I think CRP would be the cheaper option. Also, that was not clear to me.
Yeah, I love that with these podcast episodes, we have now made emotional conflict of interest a thing, because I'm going to use that all the time. I also have an emotional conflict of interest with this. I am team, I joke, but we've coined this, my friends at the Mayo Clinic and I, our team anti-calcitonin, because the Mayo Clinic did this beautiful, huge real world database showing that procalcitonin guided therapy patients actually in the wild usually have worse outcomes. And here there was actually a higher mortality signal in the procal treated arm despite less antibiotics. And I think when you're trending procals, it may actually have this like antithetical effect. And we've removed procalcitonin at my institution because of what Josh said. So I think in the early 2000s, when antimicrobial stewardship wasn't a thing and we didn't have a lot of infectious diseases trials to guide duration of therapy, I think it probably was super helpful. And it was what we see in this trial. We saw durations going from, 14 to 12 days or 10 to 8 days. But now no one should get more than 7 days for most things. And if you need more than 7 days, you have a legitimate complex infection that it doesn't matter what your procal is. So I think now we have better data and you don't need a test to tell you what duration of therapy you should give. All right, I'll go next. I am going to review the Beneficial trial, which is a multi-center randomized clinical trial to study the impact of bedside model-informed precision dosing of vancomycin in severely ill neonates and children. So this was presented by Peter de Kock from Belgium. And let me just say, they did an RCT in neonates. I can't even imagine how challenging that is to consent parents into a study like this. So unreal effort that was not talked about at all during the session. But when I saw the title, I don't know how many RCTs exist in neonates at all. And so I think this is just unbelievable effort to start off. But why did they do this? So in 2020, the vancomycin guidelines were updated, and that shifted from trough-based monitoring for vancomycin to AUC-based monitoring in both adults and children. And by and large, this was a safety move, because if you have a trough greater than 15, you will have an AUC greater than 400, just from the way maths. But if you do AUC guided dosing, you are much more likely to be under that toxicodynamic ceiling of AKI with vancomycin. So AUC guided dosing, really a safety thing. So what is model-informed precision dosing for our listeners who are not PK nerds like Anne-Grete and myself? So this is essentially, you take a population pharmacokinetics model, so you take data from all the humans in a particular kind of space. You take that model as kind of what we call a prior, and then when you apply it to the patient in front of you, you can also take into account patient-specific factors such as their serum creatinine and their weight, and you can use this to calculate or estimate your empiric, like your dose zero initial starting dose. So we call that the a priori dose optimization. And then you can do therapeutic drug monitoring to get patient-specific concentrations, layer that on top of the model as well, and that's a posterior dose optimization. So the proposed benefits to model-informed precision dosing is that you are getting the more correct dose earlier than you would with a nomogram or some other kind of, package insert or labeled dosing approach, because you don't have to wait to steady state to dose optimize. You don't need fixed time points for sampling. So that's practically very valuable, especially in pediatric patients where drawing blood is so precious and you have to kind of negotiate for what labs you're drawing with other clinical service lines because you can only take so much blood. So with model-informed precision dosing, you don't have to have an exact trough. And so you can time your therapeutic drug monitoring with other biochemical labs that are being ordered per routine care. And so I think that's a huge advantage in pediatrics. And so when the 2020 Vanco guidelines came out, they came out in April of 2020. So honestly, like some people missed them. We were all a little busy at that point in time. And it was terrible timing because we went from 1 level to 2 concentrations in a COVID world where we were trying to minimize blood draws and minimize access into rooms. So it was like really bad timing to be like, oh, hey, we're going to switch to 2 concentrations in everybody. But there was a lot of dialogue about the switch. But the bottom line was actually that AUC guided dosing did not have evidence of superiority to trough-based dosing, and people don't like to change, right? And so this group astutely said, let's do a randomized clinical trial to show if standard dosing and conventional therapeutic drug monitoring is different than model-informed precision dosing. They used InsightRx as their platform, and they randomized patients to these dosing strategies, which is so cool. So the standard arm, they got the starting dose per the institutional guideline. They dose adjusted on the institutional nomogram, and they did patient-specific trough values for the most part, what we were all doing. For model-informed precision dosing, like I said, they used a Bayesian software and a pharmacokinetics model. They used the Collin model for neonates and pediatrics. And then, like I said, patient factors go into that model. They did do TDM faster in these patients because there was no need to reach steady state for sampling. And they specifically asked the physicians who had patients randomized to this arm to order the therapeutic drug monitoring with other labs and not have a separate blood draw. And their target was an AUC of 400 to 600. They did this at 7 hospitals, 14 wards, randomized 1-to-1. There was partial blinding, so the statistical analysis people were blinded, but the clinicians obviously were not because that would be impossible. They had 150 patients in each arm, 300 kids. This is wild. 60% of them were neonates. 60%! I can't get over that. And kudos to these parents. You know, if you happen to have been a parent who consented your neonate into the study, I cannot even imagine how hard that is when you have a baby in the NICU and then you're like, sure, let's learn from them. I mean, that is just amazing. So they included neonates and children up to 18 years old, either in ICUs or on oncology units, and they had to have planned to start continuous or intermittent vancomycin with a suspected or confirmed gram-positive infection. If you were on ECMO, had severe AKI or known CKD, you were out. Not going to lie, I don't love that. I think it would be much more applicable if they included the AKI and the CKD, because practically there's a lot of pushback on investing in these kinds of softwares because they're unreliable with fluctuating renal function, as is anything, but that's most of our hospitalized patients. I would have liked to see how these softwares play in patients with AKI compared to our standard care, but alas. The primary endpoint was the proportion of patients receiving the target AUC between 24 and 48 hours after the start of vancomycin, and that was achieved in 53.9% of patients in nomogram dosing versus 71.8% of patients in the model-informed AUC dosing, which was an absolute difference of 18.9%, which was significant. Their secondary outcomes were patients with new or worsening AKI, mortality, and reaching targets after 48 and then after 72 hours, so kind of these buckets of timestamps day by day. There was a 22% difference in favor of model-informed precision dosing in achieving your target at 48 to 72 hours and at greater than 72 hours, so it was like pretty consistent that you were more likely to achieve your target. And then here's an important one. AKI was 16.9% in the standard arm versus 12.4% in the model-informed arm, which was not statistically significant, but I would think we would all think a 5% difference is clinically significant. Indeed, that's sometimes the safety threshold used as endpoints in other trials for power calculations and whatnot. So I find 5% to be actually quite significant. A tertiary endpoint was the number of blood samples and the cumulative vancomycin dose. And I really love that they looked at this because we see that anecdotally, but it's true. And the authors saw this too, that using model-informed precision dosing led to quite large decreases in cumulative vancomycin dose. So you can use much less drug when you're doing AUC guided dosing, which somewhat cost justifies the software, quite frankly, because just the raw savings in milligrams of drug often kind of lend to that. So their conclusions were AUC dosing is feasible. It led to sustained improvements in PK/PD target attainment. It had a very low risk of harm, no extra patient burden, potentially less acute kidney injury, and definitively you use less drug. Thoughts?
Yeah, I can also say Peter is amazing. I know he does a lot of studies in children, and it's really nice to see. Also nice to see the MIPD is useful here, because indeed we debate on that a lot, and there's actually, even in adults, we do not have that many studies. So I really like this study as well. And using less drug and having less toxicity, I mean, that's already great. Having a huge impact of MIPD, I think it's really hard. I think it's really hard to see a bigger clinical benefit here.
Yeah, from an adult medicine point of view, I thought it would be kind of obvious that using these Bayesian modeling approaches would get you to a target level faster than using the clunky conventional methods, but I guess having demonstrated in a randomized trial is valuable, particularly in a special population like neonates. And I agree, when one switches over from using trough-based dosing to using AUC-based dosing using a Bayesian model, which we've done in my hospital, it's quite noticeable how much lower the doses are. It's a bit hard to kind of be comfortable with it when you first start doing it.
I think it also makes your practice easier because you can take any sample. You do not need to wait steady state. You do not need to take a particular trough. You can really, if you have a good model, you can actually ease the practice for nurses.
In some ways, that's kind of harder, though, because for decades we've been like hammering into people, you've got to take the trough level, you've got to take the level just before the dose at this time in the morning, etc. Now they're confused. They're saying, wait, what? So I can take it any time? I don't understand. So there's a bit of change management to be done.
I will say that.
With other drugs, please keep doing it.
Well, but that's true with, so like isavuconazole has a half-life of like 400 years, right? And so once isavuconazole is at steady state, you can check a concentration at any time. It doesn't matter, right? Peak, trough, they're all the same. I find that when I tell clinicians, when they call, they're like, it wasn't done at exactly a trough. Is it okay? And I'm like, yeah, it's fine. No worries. They don't like that answer. They're uncomfy when you're like, it's fine, So that's a valid point. The other thing I'll say, Josh, to your point, is actually one of the original observational studies in Vanco AUC dosing was done out of Detroit, and Natalie Finch, a pharmacist, was the author. And so the DMC Medical Center had been doing AUC dosing for quite some time, long before the guidance. And one of the pearls of that paper, it was in AAC, I think 2014, was they looked at like time to AKI and whatever, but in like one of the supplementary tables, they showed the cumulative vancomycin dose, and it was substantial, like 2 grams a day less. And that has always been something I've thought was so neat. And so it's cool to see that pan out in an RCT as well. But staying on the gram positive train, Anne, do you want to start the next study?
Yeah, I'm very lucky to present SNAP to Josh in this call. So this is a really cool, a nice trial that was presented at the Late Breaking Clinical Trials in Sepsis Management by Asha Bowen from Wembley, Australia. The study is called Adjunctive Clindamycin for Treatment of Staphylococcus aureus bacteremia, a randomized controlled trial within the S. aureus network adaptive platform. The SNAP platform, I don't think needs a long introduction, but basically there are the domains that are the different trials run at the same time, and silos look at different antibiotic susceptibilities. This clindamycin trial was in the adjunctive treatment domain. It was basically clindamycin versus no clindamycin. The thinking behind the trial was basically due to the virulence factors that contribute to Staphylococcus aureus pathogenicity. So, for example, the hemolysins, nucleases, proteases, limiting expression and exotoxin release could reduce Staphylococcus aureus virulence and improve outcomes. So, because clindamycin is an inhibitor of ribosomal protein synthesis, using this drug leads to reduction in exotoxin production. So they also did a pilot RCT in 34 patients, and there was no difference in the primary outcomes, the SIRS-free survival at day 14. However, the secondary outcome, which was the mortality at day 90, was 0% in clindamycin, so 0 out of 17, and 24% in no clindamycin, so 4 out of 17. So the inclusion criteria for this was Staphylococcus aureus in blood cultures admitted to a participating hospital. Exclusion was more than 72 hours from index blood culture, polymicrobial bacteremia, known positive blood culture 72 hours to 180 days previous, end-of-life care, or clinicians deems not appropriate. So there was also clindamycin-specific criteria, which was no domain-specific inclusion criteria. However, the exclusion criteria was obviously the allergy to lincosamids, receiving clindamycin or linezolid that cannot be seized or substituted, necrotizing fasciitis, current CDAD, known CDAD in previous 3 months, current severe diarrhea, or less than 4 hours since platform enrollment. So the intervention was then clindamycin or no clindamycin, so that was 5 days of clindamycin. The intravenous dose was 600 milligrams per dose 3 times a day. Oral was 450 milligrams per dose 3 times a day. The primary outcome was all-cause mortality at 90 days, and there was a pre-specified subgroups for ICU cohort, and outcome was by clindamycin susceptibility. So the secondary outcome was all-cause mortality as 14, 28, and 42 days, microbiological treatment failure, all-cause diarrhea, Clostridium difficile diarrhea, CRP change, and some other outcomes there. And there was an interim analysis after every 500 participants. So again, very impressive, of course, this platform trial. The numbers of the patients are huge. So this study that they presented was done from February 2022 to July 2025. This was 7,432 randomizations, more than 14,000 patients screened, and 4,108 participants were then in the adjunctive clindamycin trial. Between the participants, there was obviously then randomization between the groups, and the clindamycin and no clindamycin group were comparable within the 9 countries. The comorbidities were similar between the groups. Primary outcome of all-cause mortality at 90 days for clindamycin, the intention to treat population was 16.9%, and no clindamycin was 15.2%. So the adjusted odds ratio was 1.15 with a confidence interval of 0.95 to 1.39. So there was a low likelihood of superiority. The posterior probability was 0.07, futility 0.004. So in the ICU subgroup, clindamycin had 30.4% mortality and no clindamycin had 24.7%. And the adjusted odds ratio was there 1.47, and likelihood of superiority also only 4%. Secondary outcomes, the mortality was higher also at 28, 42, and 90 days in the clindamycin group. Another very important outcome was looking at the Clostridium difficile diarrhea. Clindamycin does not drive this Clostridium difficile diarrhea more than other antibiotics, with both arms at 1.9%. The all-cause diarrhea was higher in the clindamycin group, and SIRS and CRP changes were also no different between the groups. At this point, there was no susceptibility data actually analyzed or still to be performed. However, the presenter did mention that it is unlikely to affect the results. Well, the overall conclusion was that for Staphylococcus aureus bloodstream infection, there is no role for adjunctive clindamycin. Likely, it can be harmful for patients. Currently, it's unknown impact on gut microbiome because of obviously the increased diarrhea in the clindamycin group. So adjunctive antitoxin antibiotics are unlikely to have benefit. They also reference another trial looking at this. I'm going to throw this to Josh to comment on this study.
Yeah, thanks, Anne. It was really exciting to get these results when we found that the statistical trigger of futility had been hit, and eventually for us to see all the results and to present them. So I obviously have a conflict of interest being one of the global co-leads of the trial along with Steve Tong, but also worth mentioning there are literally hundreds of investigators around the world that have worked on this trial, including people that are on this podcast, Marc and Erin and Emily, who would have been here. So I guess a couple of takeaways from this. One is it's very clear that clindamycin was of no benefit in the population overall and was of no benefit in the ICU subgroup. And in fact, the likelihood of superiority in the ICU subgroup was 4%, which really is mathematically exactly the same as the likelihood of it being inferior was 96%. The likelihood of mortality being higher in the clindamycin in that ICU subgroup was 96% based on the Bayesian posterior probability model. So that's pretty worrying, and we don't know why that is the case, if it's even true, but we think it may be something to do with disturbing the gut microbiome, because there's more and more emerging data that exposing people to unnecessary anaerobe disturbing antibiotics is bad for outcomes in animal models and human observational studies of sepsis. And that's why the latest surviving sepsis guidelines has recommended avoiding meropenem and pip/tazo if you don't need them. And then the other thing we were kind of, I guess, pleasantly surprised about is that the rate of C. difficile diarrhea was like exactly the same in the two groups, and it was quite low, 1.9%. And when we were setting up the trials, a lot of colleagues at some sites and even whole regions said there's no way I'd randomise patients to get clindamycin because of C. diff. As far as I know, this is the largest ever RCT of clindamycin for any indication, and there's very clear data here that if used in these doses for just 5 days, it doesn't increase your risk of C. difficile more than other antibiotics. So yeah, that's all I'll say here. There's more analyses ongoing and we're preparing the paper for publication.
Do you think, Josh, that there could be like more subgroups here? Because obviously the population is really heterogeneous, big population. Would there be benefit in looking at some other subgroups, do you think?
It's a pragmatic trial, so we've purposely not collected a whole lot of detailed data, and we're also very careful to limit our subgroup analyses to a priori ones, so to avoid kind of false discovery. The key subgroup that we hypothesised would benefit the most was the subgroup that are critically ill, the ICU subgroup. Other subgroups, such as necrotizing pneumonia, for example, we don't really have sufficient data collection to look at that.
Thanks, Josh, for the commentary.
So this notion that maybe the disturbance of this anaerobic flora has an effect on patient outcome that you will only see with so large numbers actually is a concept that was proposed in the 1970s by a Dutch medical microbiologist, Dirk van der Waai. And this actually was the basis of what is now called selective digestive decontamination. It started with the notion that if you eradicate the anaerobic flora from gnotobodic mice without other flora, that it will kill them. So it will make them more susceptible to invasive infections with other bacteria if the anaerobic flora is disturbed. It's the concept of colonization resistance. So maybe, that's the reason.
Thanks, Marc.
I will actually go even further, Marc. Marc wrote a very nice pro-con piece with Josh, right? Was it Josh and Marc? You guys wrote a pro-con piece on STD, right?
Yeah, I think so.
All right. Well, yeah, it's good. Plug it.
Okay, so we've been talking about gram-positive so far, the vancomycin and the Staph aureus, and now we're going to go to gram-nothing, the mycoplasma.
Ooh. Okay,
so,
that was good.
Angela, do you want to tell us about this mycoplasma pneumonia trial?
I do. I really do. So this next trial is entitled Adjunctive Betamethasone Treatment of Hypoxemic Adults Hospitalized with Mycoplasma Pneumonia, Community-Acquired Pneumonia, an open-label, multi-center, randomized controlled trial. It was presented by Dr. Carl Hagman of Gothenburg, Sweden, in the ESCMID Global's new late-breaking research from the Lancet session. So this trial has been published already. You can find the entire report in Lancet Regional Health. So as we know, there are now several trials with conflicting results on whether steroids as adjunctive therapy improve clinical outcomes in people with pneumonia or not. And in fact, we are going to be doing an episode on this. That'll be coming up not too far from now. The theory behind this, of course, is that our own inflammatory reaction in the lungs is what needs subduing. And since the pathophysiology of severe community-acquired pneumonia with mycoplasma pneumonia involves an exaggerated host response, these investigators thought they would have the right population to test their hypothesis that corticosteroids would be beneficial. So in this trial that took place in 8 Swedish hospitals, 70 hypoxemic adult patients were randomized 1-to-1 to either standard of care, which was antibiotic therapy only, or standard of care plus 5 days of adjunctive betamethasone, dosed at 3 milligrams on days 1 and 2, and 2 milligrams on days 3 to 5. And the antibiotic in both arms was standardized to doxycycline once patients were enrolled. So the primary outcome was a continuous one, which I love. Time from randomization to regression of hypoxemia, which was defined as an oxygen saturation of at least 93% and a respiratory rate that was below 20 without needing any supplemental oxygen. So to get into this study, patients had to be 18 years or older, non-pregnant, and they had to have at least an X-ray or CT scan confirmed pneumonia with an airway sample showing mycoplasma pneumonia by PCR. And patients had to be hypoxemic to start. And again, that cutoff was at 93%. Main exclusion criteria were an alternative airway pathogen, asthma, and COPD, as was compromised immunity, which even included diabetes. These patients were followed for 56 days, and there were several secondary outcomes, including a patient-reported symptom questionnaire, which is called the CAP score. So overall, 212 patients were assessed for eligibility, of which 70 were randomized. 36 were assigned to betamethasone and 34 to standard of care. So they nicely report intention to treat results. This population was fairly young, median age of 36 in the betamethasone group and 38 in the control group, more men than women, 53% men in the betamethasone group, 62% men in the control group. They were fairly healthy, 65% of patients had no comorbidities. Median symptom duration was 11 days, quite long, and patients were randomized at a median of 2 days after admission, so they were getting to them pretty early. So what were the big results? Time to regression of hypoxemia was shorter in the betamethasone group, with the estimated median time being 2.3 days in the betamethasone group and 3.6 days in the control group. This leads to a hazard ratio of 1.8 with the 95% confidence intervals between 1.1 and 3.0, or by p-value, it was a p-value of 0.02. So small groups. The length of stay was also significantly shorter in the betamethasone group, hazard ratio of 2.1 with 95% confidence intervals being 1.2 and 3.4, but the CAP score didn't differ significantly. Adverse events were very few. There were essentially no safety signals. So all in all, this is basically more evidence for the pro arm in the steroids or not debate, but it's a nicely pathogen-specific argument here. I think overall it's quite a nice, elegant trial. It does, of course, come with some limitations. It's very small. The authors do acknowledge them well in their full publication, which we have access to. The biggest limitation, of course, is the open label design coupled with a primary outcome that does look objective at first appearance, but could easily be a little influenced by someone with a bias. As the authors themselves note, they say, you never know, an unblinded nurse could have initiated earlier oxygen weaning and monitored oxygen saturation and respiratory rate more frequently. So there are some things to keep in mind as you look at their results. But overall, I would say it's a very nice addition to the repertoire and certainly more fuel for the debate. Marc, tell us, what have you got?
Yeah, so I'm puzzled by the extreme effect on the length of stay with an hazard ratio of 2.1. What were the actual numbers of these days? Because the effect on the length of stay is even longer. And let's say the hazard ratio is even higher than for the shortness of breath or whatever.
So estimated median duration of hospitalization was 2.9 days from randomization for the betamethasone group and 3.9 for controls.
A full day.
Yeah, so a full day, which we can safely say has to matter to patients. I mean, the worst thing is being stuck in the hospital, right?
Yeah.
I think overall, I would say this is an open label trial with not really an objective primary outcome. I really think people could have been behaving differently, and that could have led to people going home earlier.
Well, steroids make you feel better.
They do. They do. The counter-argument would be, that's the point. Look, we get to go home early, whether we're biased or not.
That's why we give them.
I guess one thing I'd add is this is a very niche group of patients, right? Like most people who get mycoplasma pneumonia do not get hospitalized or get hypoxemic. They have a headache and a dry cough and they're treated as an outpatient. So obviously these results do not apply to those patients and should not be applied to those patients. Secondly, most patients with mycoplasma pneumonia are never diagnosed with it because they don't have a PCR done, or they may get diagnosed by serology later on. And thirdly, excluding people with diabetes seemed a bit weird. Like I almost never have any patients in hospital that don't have diabetes. Although I guess
these were younger.
These are young people. Mycoplasma tends to affect a different population. I think it's nice. It, as you say, adds to the weight of evidence supporting steroids. There's some caveats here, but I mean, I think if I had a young non-diabetic person with PCR confirmed mycoplasma who's hypoxic, I'd probably give them steroids. But I can't remember the last time I saw that exact type of patient.
No, fair enough. That's always how representative is this trial, let alone this patient. But on the other hand, I like that we're moving to pathogen-specific questions and investigations. And I think we do need to be more individualized in general in our thinking and our approaches to patients and to their therapies. I do think it's quite elegant in that they say, look, we're going to find the population where we could show this difference, on a low budget. It's a very small trial. And I think that is a very smart approach, right? We often do these big trials where we dilute out any signal because we're including everybody.
Yeah. And to be fair to them, a lot of multiplex PCR panels are available now that do include mycoplasma.
More.
So, yeah.
I know that there are periods and places where there are epidemics of mycoplasma, right? It does tend to be very sporadic. I know there was quite a big outbreak in Israel, right, 10 years ago. And they really were able to put out quite a lot of output.
Yeah, that's a good point. It tends to come in epidemiological clusters. So we've gone through some gram-positive trials, then we've gone no cell wall. And so let's end up on some gram-negative focused work now. So I'm going to talk about the EMBRACE trial, which I noticed when I was reviewing this that Marc Bonten is the senior author on the abstract, and it turns out that he was chair of the study steering committee. And also Angela was involved in the earlier phase trials developing this vaccine and in this trial. So to both of them, kudos for a huge trial, which had a definitive result, which we'll talk about in a sec, but also no thanks to you because it was a very hard trial to do as a site investigator. That's my, not conflict of interest, but involvement was I was a site investigator in this trial, and it's probably the most difficult, hard work trial I've ever done. We can talk about that another time, but anyway, so the trial looks at people with recurrent UTIs or at least one previous urinary tract infection. And this is a common and difficult problem. And our current tools for prevention are pretty limited and suboptimal. We sometimes end up putting people on long-term suppressive antibiotics as much as we don't like to do that. Methenamine hippurate has some good evidence, but a modest benefit. So in that context, people have been trying to develop other strategies such as vaccines. Most UTIs are caused by E. coli. And so Johnson & Johnson, correct me if I say anything wrong, Angela, Johnson & Johnson developed this vaccine that's directed against the 9 most common serotypes of E. coli. We'll just refer to it as their 9-valent E. coli vaccine. So this was a huge trial. It was a registrational trial, i.e. with the aim of registering this vaccine. So it was very rigorous. They enrolled people aged over 60 years who'd had at least one UTI in the past 2 years. And then I think the protocol was changed partway through to enrich the trial for people with at least one additional risk factor for recurrent UTIs. People were excluded if they had immunosuppression or were on long-term antibiotic suppression, which from my point of view, a lot of the patients I see that kind of was my motivation for getting involved in this trial couldn't go in the trial because they were on long-term suppressive antibiotics or they were immunosuppressed. So the trial was terminated early at an interim futility analysis. I'm not sure what the total planned sample size, but at this interim analysis, there were 17,637 people. So a huge number of people were already enrolled and randomized with follow-up when this futility decision was made. And these 17,000 odd people were enrolled at over 332 sites in 20 countries. I can't imagine how much this whole exercise cost, but it must have been exceedingly expensive. People were randomized 1-to-1 to either receive this 9-valent E. coli vaccine, a single intramuscular dose, or placebo, single intramuscular dose. And the mean follow-up was 18 months. The original planned follow-up was 4 years, but at the time of this futility stopping, it was 18 months on average. The primary endpoint was invasive extraintestinal disease caused by vaccine serotypes of E. coli. So that was basically bacteremia. It could be other sterile site isolates, but it was pretty much bacteremia caused by vaccine serotypes of E. coli. And disappointingly, out of over 8,000 patients, there were only 11 patients who met the primary endpoint in the vaccine group and 13 in the placebo group. So really there was no difference there, and that gave a calculated vaccine efficacy of 14.6%. when you take into account the denominator of number of patient days of follow-up. And there were similar results for really all the other analyses, including numerous secondary endpoints. And this includes UTIs caused by E. coli, not just bacteremia, UTIs caused by any organism, and then also looking at subgroups of those who were at higher risk. So in all these secondary analyses, there was really no benefit of the vaccine. So just for example, UTI caused by vaccine serotypes, there were 454 of these events in the placebo group and 415 in the vaccine group. So slightly numerically less, but not significantly different at all. And that gave a vaccine efficacy of 8% against UTI by vaccine serotypes. So the vaccine did induce appropriate antibody responses in a subset where that was measured, and it had an acceptable safety profile and the expected safety profile. So a small proportion of patients got a sore arm, for example, but there was nothing unexpected there. Interestingly, some of the patients I was looking after who were on the trial had told me, oh, I'm sure I got the vaccine because, I was getting recurrent UTIs, and then they stopped. And other patients told me, I'm sure I got the placebo because I'm getting just as many UTIs as ever. But now it's all unblinded, and I've been able to tell the patients what they got, and none of them got what they thought they got, which is just a good advertisement for why we need blinding in trials. Overall, this is a huge disappointment. I do wonder if it was the right outcome. They set a very high bar for themselves, the outcome being invasive, basically bacteremia with vaccine serotypes of E. coli, and you could have used something more common like recurrent cystitis, for example. However, this also showed no difference, so it wouldn't have, in the end, made a difference. I mean, Marc and Angela, you know this well. Why do you think this failed?
Well, I can say a few things. First of all, let me describe how this all went, because this is a story ongoing for more than 10 years. Also my involvement in advising them how to set up the study. And the vaccine was initially developed by Janssen Vaccines. That was then taken over by Johnson & Johnson. And I think 6 months before the futility analysis, actually, the whole vaccine program was taken over by Sanofi. So actually, think of what they bought. There was a long discussion with FDA on the primary outcome of the study. How should the primary outcome be defined? And with these vaccine producers, they want to target an endpoint that allows them to get into a national immunization program. That's their goal. So an endpoint of less recurrent infections in patients with recurrent infection would limit the population eligible for their vaccine enormously. And that then would be considered probably internally as not worth the effort to go all the way to get a vaccine with a label for a very small patient population. So the enormous costs that come with such a study, I think, forces them to go for an endpoint that would allow the vaccine to be included in an immunization program if demonstrated to be cost effective for the standards for including such vaccines. And I think that's one of the problems that we see with these vaccines for the elderly, also with the respiratory tract vaccines. The goal is to get it into a national immunization program. And maybe that bar is too high and that we are missing vaccines that can be beneficial for some indications, but probably the indications and the populations go with that indication are too small to make it worthwhile for the producers to make such vaccines. Now, what now is the reason that it failed? Actually, I don't know, because there is, of course, no correlate of protection for the antibody activity. There was a significant increase in antibodies that could be measured between the vaccine group and the placebo group. But apparently, that difference was not sufficient to cause a difference in this primary outcome and in all the other outcomes. So I'm afraid we will never know, unless Angela is now going to telling us why.
First of all, I would beg to differ. It was not Janssen who initially developed the vaccine.
No, they bought the Swiss company.
Yes, we are very proud here in Switzerland. It was a Swiss startup that actually created the vaccine, and that's how I got involved. We trialed it. It's a conjugated vaccine, so quite immunogenic because it's conjugated. So we did that phase 1 early study in healthy women who had histories of recurrent UTI. So we were able to look at, actually, it was really cool. It's probably the only time in my life where I'll do a phase 1 vaccine trial where you can look at safety and immunogenicity, as you must, but also clinical outcomes. So Janssen came along and bought that vaccine because that first trial was showing some signal of clinical efficacy there. It was very slight, and the study was not powered by any means for clinical outcomes, but the vaccine group was doing better with their recurrent UTI. So that's what started everything, I believe. And yeah, to answer why it failed, as Marc says, the primary outcome, that is a really tough one. Going for invasive E. coli disease, it's rare overall on a population level. We all know it's very rare. And like you were saying, Josh, the person who's going to get E. coli bacteremia, that person is not likely to be immunocompetent or young, right? We know these patients. These are the urosepsis patients in our hospitals who are immunosenescent or medically immunosuppressed. So it's a catch-22. I mean, you're giving a vaccine to a population that is already disadvantaged in its response to that vaccine, right? And then what I've heard from investigators on the ground, I don't know how you feel about this, Josh, but Merel Lambrechts in the Netherlands as well, she told me she was an investigator that recruited quite a lot of patients, and she's really convinced that they were just missing a lot of events because the patients weren't able to report every single cystitis or whatever. They're sure that they missed a ton. Bacteremias, maybe not. Again, the primary outcome was such a hard one, but the UTIs, she's convinced that the study didn't really equip them to find every UTI that was happening on vacation on a Friday. As we know, UTIs always happen on the weekend, when people are away. So she's pretty convinced that they just missed a whole lot of events. I don't know if you had that experience.
Probably not. I mean, we biased it towards patients we knew we'd be able to follow up and weren't going to be traveling and that kind of stuff. And they were on the phone to my research nurses all the time, every time they got a stomach ache, and were sending urines. It was just a huge amount of work. So I don't feel like we, in the trial in general, or at some sites at least, missed many UTIs. We may have missed getting urine collected in time to know if it was a vaccine serotype. But yeah, Marc, correct. I don't remember exactly what the cutoff was, but I think they were going with the old FDA guidance because, like Marc says, this dates back like 10 years. So I think they needed very high colony counts in the urine to be able to call it an actual, positive culture. E. coli, as we know in real life, E. coli can cause symptoms, a real UTI, with 10 to the 2, with very few colony counts, which many labs can't even measure. So that may have also played a role.
I don't know by head, but I think we can assume that this loss of endpoints was non-differential. So there was no reason to believe that the intervention itself resulted in extra loss or vice versa. So that would not change, to me, would not reduce the scientific validity of the comparison between the two interventions. It just takes much longer to come to an answer if you miss a lot of endpoints. And sure, there would be a loss of endpoints in any such trial, missing endpoints.
No, I agree with you that things should have been missed equally, right? Because these patients were randomized. So events should have been missed everywhere.
And it was very double-blind, as we heard from Josh.
Yeah, but still, I think the trial was stopped for futility because they just didn't have enough events, right? On either side, if you just had a richer
No, it's not stopped because the analysis was based as planned. It only took much longer to get to that number in which the first interim analysis was done. So I think the total sample size was twice the number of these endpoints.
But that's just it, because there were so few events, right? They couldn't come to this first analysis. They had to get to 17,000 patients to be able to do the interim.
I think the enrollment was still going. So I think the plan was to go to over 20,000 to get in total, I think, to about between 50 and 60 primary endpoints. So when they came to about 30 that they have now, that was the planned first interim analysis. And there were stopping rules with that interim analysis. So no one had expected that the estimate vaccine effectiveness would be, let's say, 14% at the first interim analysis, which hit the trigger to stop
the trials and tribulations of clinical trials, hey? Like, we never know when we're starting a clinical trial what's going to happen, and that's one thing that's fun and exciting about doing them. Sometimes disappointing and sometimes exciting. But so that was the last trial we were going to discuss. One little side comment I think I might make is that you may have noticed these late breakers we've been discussing. A lot of them were presented in journal-branded sessions. So JAMA had a session, The Lancet had a session, CMI and CMI Comms had a session, but notably absent was New England Journal of Medicine. So here's a challenge that I'm throwing down. New England Journal, come along to ESCMID, like all the other major journals do, and sponsor a session and come and commission some excellent studies to be published in your journal.
In return, we promised the New England then to send our best papers there.
Yeah.
Thank you so much for the conversation, and thank you for listening to Communicable, the CMI Comms podcast. This was part 2 of a 2-part episode about top trials presented at ESCMID Global 2026. This episode was edited by Katie Hostetler-Oy. The theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks. And any published literature we've discussed today can be found in the show notes. You can subscribe to Communicable on Spotify, Apple, wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.